Good afternoon, everyone, and thank you for joining us today. I'm Janelle, Business Development Manager at One Heart Clinic, and we are delighted to host today's 45-minute CPD session on sports cardiology for primary care. With the London Marathon having just taken place last weekend, it's a timely reminder of how many patients we see who are engaging in endurance sports, whether that's running, cycling, or returning to exercise after illness. So GPs are increasingly asked to assess cardiovascular and respiratory symptoms in active individuals. So today's session is designed to provide a practical structural approach to exercise clearance, including identifying red flag symptoms, interpreting common diagnostic testing findings in athletes, and making safe, evidence-based referral decisions. We are joined by two excellent speakers today, and we will finish with a Q&A at the end. Please feel free to drop your questions into the Q&A box as we go along, and our speakers will try to address them during the session. Now, I'm delighted to introduce our first speaker, Dr. Gulam Haji. Dr. Haji is a consultant pulmonologist at Hammersmith Hospital, part of Imperial College NHS Trust, where he works within the National Pulmonary Hypertension Service. He co-leads the Cardiopulmonary Exercise Testing Service and has extensive expertise in breathlessness, exercise intolerance, and cardiorespiratory physiology. His clinical work focuses on conditions such as pulmonary hypertension, pulmonary embolism, and unexplained exertional symptoms, making him ideally placed to support primary care clinicians in assessing active patients with respiratory and exercise-related concerns. Now, Dr. Haji, we are delighted to have you with us today, and over to you now.
Thanks very much, Janelle. I hope I'm nice and clear and you can all hear me. I'm just going to start sharing my slides, and then we'll get going. So yeah, thanks, Janelle, for the introduction. As Janelle said, I'm a respiratory physician at Imperial College, which is where I spend most of my time. And here we run a cardiopulmonary exercise testing service. As of middle of 2025, around May 2025, we were able to set up and replicate an excellent service at One Heart Clinic in this regard to help with our assessment of patients presenting with cardiorespiratory symptoms. The theme of today is athletic individuals and symptomatology. I anticipated following Dan, which would have been nice for him to set the scene from a cardiovascular perspective, but I'm going first. So I hope that I can just take you through some points, really, when thinking about the assessment of highly athletic individuals, of which we are seeing more and more now, not just bona fide athletes, but people in the sort of health and wellness sector now with supernormal levels of VO2 that may well be presenting with relative exercise limitation and symptoms, particularly of breathlessness. So it's a very common clinical presentation. We see it in all forms of sport. Now, interestingly, breathlessness, aside from any injury-based reason for an athlete to present to a clinician, is the primary symptom that is described in athletes that are performing under duress effectively. Breathlessness itself, we know, is a very, very common presentation. I think those in primary care, those in emergency medicine actually are at the sharp end of this, and they see this much more and they deal with it in a much better fashion, really, than some expert cardiopulmonary physicians. But 1 in 20 presentations that we see in primary care is due to breathlessness. I think for the athletic populations, it's very clear that we should be aware that it's pathological if it occurs in unexpected situations or what one would consider light exertion. And I think that's quite interesting when we assess athletes, particularly using VO2 max testing and cardiopulmonary exercise testing, is to try and understand what their relative starting point is. So very, very regularly, we'll see people with a VO2 max of 160, 170% predicted. And if they drop down to 130 or 140, they've lost a significant amount of performance ability. And if that drop is due to cardiopulmonary symptoms, and we can't obviously explain what those symptoms are being driven by, given that the overwhelming pattern of physiology at exercise testing looks normal, then we can find ourselves in a slightly difficult situation. I think a logical, systematic assessment is very, very key. Concerns for athletic individuals is that they want to really be satisfied that there is no pathological explanation that's been overlooked. So before falling down on the side of relative deconditioning or indeed overtraining, compromising performance, you need to make sure that you've systematically assessed them. I think for physicians looking after highly athletic individuals and indeed the general population, there is a degree of professional uncertainty, particularly where you may lack a clear diagnosis. So I think breathing in sport really has taken the forefront. I think a lot of you on here may know James Hull, so he is a good friend and an excellent exercise physiologist, mentor in this area actually, who is a leading authority on a lot of exercise-induced breathing problems. For many, many years, particularly in the physiology world, we never really thought of the respiratory system as being a limiter to exercise. For athletes and the general population, we should in theory be limited by the mechanics of oxygen delivery or utilization. So even when we're performing at VO2 maxes of 140, 150% predicted, it will be our cardiac performance effectively that tops out, or our musculoskeletal ability to extract oxygen from the blood and translate this into energy for us to continue doing work. And over time, I think what we've started to realize is that although that's the relative limiting system, delivery utilization, the predominant symptoms seem to be respiratory, with breathlessness being the key to this. If we then look at some examples from general health and patterns of testing, it becomes very interesting when we start to break down which particular systems are contributing to breathlessness in different population groups. So if you look at some of this data from the expert reviews of respiratory medicine published in 2023, looking at clinical evaluation of patients with unexplained persistent dyspnea, you can see here that cardiac and respiratory causes only make up about 50% of these presentations. I would argue that some of the other causes that make up the majority group are actually related to the respiratory system. So when we're thinking about breathing pattern disorders, when we're thinking about things like musculoskeletal intolerance and how we actually process carbon dioxide, how it's being returned back to the respiratory system, and thinking about respiratory compensation and how that can affect how breathless people feel. This slide here looks at how the NHS England pathway tells us to assess the breathless individual. I think this is important. I'm not sure I like it all that much, given that I think it provides a good framework. However, it is a guideline, and I think that we have flexibility to work within this guideline to change how we approach patients. It may not be the best thing to do to, just do an NT-proBNP, a chest X-ray, and then start moving straight towards a CT thorax and pulmonary function without considering echocardiography and dynamic function assessment in individuals where you know that the clinical history may, for example, be pointing towards a breathing pattern disorder. You've always got license in these people as well to ensure that you've excluded, difficult pathological processes, which can be done quite quickly, and then implement a decision aid or a treatment approach to these patients, and then see them for follow-up in a few months' time to understand how they progress before moving on with advanced testing. This is my last slide on sort of general stuff before focusing in on the athlete population, but we know that cardiopulmonary exercise testing is a very, very useful adjunct. The group at Boston, Massachusetts, David Sistrom, Aaron Waxman, who are leading lights in the world of cardiopulmonary exercise physiology, demonstrated that if you took a static combination approach to the workup of patients with breathlessness, you've only got diagnostic yield of about 40%. And granted, in these individuals, they were using invasive cardiopulmonary exercise testing, whereby you actually put a right heart catheter in to the right-hand side of the heart and the pulmonary circulation to evaluate hemodynamics with exertion. What they found with dynamic function assessment in this regard, that you increase your diagnostic yield massively. And of the remaining 530 patients, they came up with a diagnosis in about 467 of those individuals. Now, when you're thinking about highly athletic individuals, and the BTS clinical statement for the assessment here doesn't necessarily mention the athletes, it talks about highly athletic individuals. I think one of the key determinants here is that it says that your general approach to assessment should be as it would be for anyone else, particularly where you see red flag symptoms. So you shouldn't overlook very important clinical features by virtue of an individual's athletic status. And I think this can be very much more difficult, for example, given their compensatory mechanisms. When you're thinking about things like thromboembolic disease, potentially low burden thromboembolic disease, they might not mount some of the early responses that we would expect, like a relative tachycardia, and their symptom burden might be quite low. They're also at higher risk if you think about, dehydration, travel, etc. So all of these things should stick out in your mind. The one thing that has become clear in the approach to assessing respiratory health in athletes is that there is a multi-system and a multidisciplinary way that we need to go about this. So we know from evidence in asthma previously that if you take asthma individuals who have refractory symptoms, you focus purely on optimizing inhaler strategies and the benefits of maximizing the FEV1, you're missing a whole host of other comorbidities that will contribute to ongoing symptomatology. And in effect, you can be over-treating pathology that does not need over-treating. So Jim Hull published this in 2021 with a group of individuals talking about the benefits of a systematic assessment of respiratory health in athletic populations, recognizing the importance of evaluating the nose, the upper airway, breathing pattern characteristics, and for allergy, for example. And what they found in that study was that people presenting with breathlessness who are highly athletic will fall into two discrete cohorts. So those with asthma or exercise-induced bronchoconstriction or lower airways dysfunction will overlap with rhino-nasal problems and allergy. And then there's a distinct cluster with inducible laryngeal obstruction and breathing pattern disorders, noting as well that there is overlap between those two cohorts. And this is quite a nice algorithm. So when you think about this, you've got your common symptoms, which point towards asthma, EILO, and BPD. And then you've got your red flag symptoms. I think this is where you can often overlook patients. One of my areas of interest, obviously, in the pulmonary circulation is with non-cardiogenic or exercise-induced pulmonary edema, which we do see. We see it in high-altitude athletes. We see it in swimmers, particularly swimming open water, where they have the compression of the tight wetsuit that alters the hemodynamics of the right atrium, pulmonary circulation. And what we often do in these situations is embark upon a cardiac diagnostic pathway, which is very, very important because it's the cardiac conditions that we don't want to miss that contribute to sudden cardiac death in athletes. Once these have been excluded, I think what sometimes gets forgotten is really the venular system. And dysfunction of the venular system with non-cardiogenic pulmonary edema can be a form of fruit presentation or an early precursor warning event for people that may have more significant pulmonary vascular abnormalities. And again, cardiopulmonary exercise testing becomes very, very important here because we've certainly had, cases, few and far between, I agree, where people have presented, for example, running cross countries or marathons in their teenage years with non-cardiogenic pulmonary edema, had a very, very reassuring cardiac workup. When you exercise them on an exercise bike, what you start seeing is surrogates of pulmonary vascular dysfunction. So early evidence of ventilatory inefficiency and gas exchange dysfunction, early evidence potentially of exercise stroke volume limitation. So it's the red flag conditions, I think, that we need to make sure we are managing as we would for anyone else. But the common symptoms are really what we're thinking about when we look at these athletes presenting. I'm not going to dwell too much on this. This just basically tells us, what types of cardiopulmonary exercise testing we can do. The standard exercise test is very amenable to most, expert centres. There are a few excellent ones in the private sector. There are some very good NHS services in the local area as well. And when you're thinking about more advanced testing, for example, with venular disruption, dysautonomia, you might be moving towards an invasive exercise hemodynamic assessment. Obviously, with inducible laryngeal obstruction with exercise, the gold standard therapeutic approach is continuous laryngoscopy during exercise. And this is where I think it gets quite interesting. So it's the pathogenesis and the pattern of symptoms that people present with. And I think that can be quite key. So it can be quite difficult. And I had a recent case actually in a combat sportsman who was training, who at high intensity on an air bike got very, very reproducible symptoms. In my opinion, it sounded quite airway-like. There is a definitive overlap between obviously symptom presentations for cardiopulmonary conditions. To cut a long story short, after a relatively succinct work over a 7 to 10 day period, it was quite clear, even with some sort of masking from some of the respiratory tests and attempts to use inhaled therapies to potentially treat exercise-induced bronchoconstriction, that the problem was with a coronary artery. So the overlap in symptoms is key, and I think it's about, making sure you're doing the correct diagnostic tests which overlap between both cardiac and pulmonary systems to not miss an underlying pathology. And again, that's where CPET can be very, very useful. But the patterns that we see, so with inducible laryngeal obstruction with exercise, people often describe a tightness in the throat. There is a sort of particular pattern that becomes apparent at peak exercise. And what you get is you get folding or closure of what generally tends to be the supraglottic structures, which affects the transit of airflow into the middle and lower airways. Now, if you can detect this with continuous laryngoscopy with an exercise, knowing that this probably affects about 5% of athletes, and there's good robust data to support that statement, you can really optimize their performance going forward. And particularly with the onset of this in early adolescence between the age of 12 and 15, and the overlap with EIB and BPDs, and obviously, the want and the need potentially to treat something, which is where inhaled therapies get given out, quite significantly with little benefit. If you start missing this condition in early adolescence, what you find is you can impact performance when people are trying to break into national teams, thinking about, how they are going to progress as an athlete. With EIB, very interestingly, people often report cough, inspiratory and expiratory symptoms. The onset tends to be just after peak exercise, and it has a more protracted course. It can take 30 to 40 minutes to slowly resolve. Now, this can signify poorly controlled underlying asthma, but in itself, it is a separate entity. And we'll talk about this in a bit more detail, because I think the pathology of this condition is actually very, very interesting. BPD coexists with all of these conditions, but can also be a separate entity. What we often see here is fluctuation and variability in symptoms. It may not have a bona fide association with exercise, and there can be some other associated symptoms of hyperventilation. So exercise-induced bronchoconstriction, when we're thinking about that, is probably the most common form of airways disease in athletes that mimics a whole host of symptoms, more common than EILO. I don't know exactly what the prevalence of BPD is in the athletic population, because that data is not as robust and it's very, very subjective. But you need to stimulate environments whereby patients will constrict their bronchi. So the thought and the hypothesis here is that when you excessively increase dynamic flow through the airways, particularly in dry conditions, particularly in cold conditions, you dehydrate the airways. The airways are then prone to releasing sort of mast cell mediators and cytokines, which cause bronchoconstriction. Now, exercise on an exercise bike and CPET can be a useful thing here, but you've got to remember that you're not recreating the conditions exactly, because you've got a mask on, the air is more moist, the environment may be warmer, so you might not get the symptoms. But the eucapnic voluntary hyperpnea test, where you effectively get people to breathe a dry gas mix at varying volumes in accordance with what their maximal ventilatory limits are, and then check FEV1s periodically thereafter, looking for a fall of greater than 10%, you have a very, very good diagnostic field. The important thing there is once you've got the diagnosis, you can start thinking about the management. And these are not always pharmacological. So there are warm-up ways that you can implement. There are different therapeutic strategies that you can use. There is a significant overlap with the management of asthma, but you'll see that the specific therapies, as discussed here, are different, and they are not as straightforward for EIB. You have to be quite careful in terms of using short-acting bronchodilators with SABA inhalers, because you do get tachyphylaxis, you do develop tolerance over time, and also that can have implications in terms of the dosings, etc. So I think this is very interesting. Once you've got your diagnosis, why do things not just get better? Well, I think this is where the complex interplay is something that we need to think about. So you diagnose EIB, you select one of your inhalers with the therapeutic strategies, people are still breathless. And I think that's where the the interplay between the upper airway, the middle and the lower airways comes into play, and also with breathing pattern dysregulation. So if, for example, you've got an allergic history that you're not treating and you've got nasal problems, you've got occlusion of the upper airway, you find that people mouth breathe more. That dries out the larynx, that can predispose them to coexistent induced laryngeal obstruction. Over time, with their perceptual responses and also the anxiety of the ongoing symptoms, despite optimal management in inverted commas, the breathing pattern can change. So it really is a combined approach. And I think respiratory physiotherapy, speech and language therapies are two of the most important adjuncts for athletic individuals presenting with breathlessness, where we see vast overlap between three distinct clinical entities. So just a quick look for the last, I think we've got 2 or 3 minutes left. A case in a highly athletic individual of relative exercise insufficiency. So this is an individual who's actually close to 60, who cycles at a very, very high level. Now, the first thing that we can see here, if we look at the top left-hand side of the screen, if we just look at the VO2 max, you can see that this individual reaches a VO2 max of close to 4 litres per minute. And if you adjust that for weight, bearing in mind the weight's about 70 kilograms, you're looking at a VO2 of about 60 mils per min per kilo, which is exceptional. So highly athletic. There is relative exercise intolerance here, which is interesting, and there is a predilection for symptoms, which cannot be ignored. When we work through and we think about cardiovascular performance, which we've got here, this particular graph here looking at the oxygen pulse profile, which is a surrogate of cardiac volume function, and looking at the heart rate response to exercise, what we can begin to understand is there does not appear to be any cardiovascular limitation in this particular setting. Again, likewise, graphs here looking at blood pressure responses against load output look excellent. What we can see, though, is if you look at how minute ventilation changes with exertion according to load, ignoring the breathing pattern, which I'll come to at the end, you can see distinct changes in the way this individual is ventilating during exertion. Then, if we can concentrate on this particular graph here that I've arrowed, and you look at the breathing pattern here, and you put that next to the pre-test spirometry that we get, we can very quickly start to see that there is a problem. So towards the end of exercise, particularly, given that there is some variability early on, there appears to be cycling of tidal volumes and respiratory rate with significant heterogeneity and overlap of these two particular panels. And if you put that together with the flow volume loop, where you've got attenuation of the inspiratory limb and also some notching of the expiratory limb, you can start to see that this individual who's highly athletic with a VO2 of 60, who's complaining of cardiorespiratory symptoms, who's had a very, very reassuring static workup, has got problems that can probably be quite easily rectifiable with some degree of upper airway training and in breathing pattern. And I think this exemplifies some of the things that I've discussed already with EIB, EILO, and breathing pattern disorders. So just to summarize, so when you're assessing symptoms in an athletic individual, just follow a logical and systematic approach. I think the red flag symptoms, as we discussed, should be approached as we would for anyone. There is a vast heterogeneity in presentation and often a complex overlap between the three common syndromes that we've discussed. Exercise, advanced diagnostics are key, but obviously the basics are very good. So as a respiratory physician, we're looking at blood eosinophil signals as a marker of airway inflammation. We're looking to make sure that low hemoglobin and iron levels are not being missed. We're thinking about oxygen transport and oxygen utilization and basic things like thyroid function testing. I think where answers are not obvious, and I have, I've seen this, for example, with exercise pulmonary edema, SIPE, HAPE, etc. Think about other systems, venular disruption, I think there's a lot to be said about a complex multidisciplinary approach between cardiac and respiratory physicians who have quite a lot of expertise in this area. So I think that's it from me, coming up to about 20 minutes. I'm happy to answer any questions in the chat or thereafter.
Yeah, thank you very much, Dr. Haji, for those valuable insights. And now it's my pleasure to introduce our second speaker, Professor Daniel Augustine. So Professor Augustine is Medical Director of Sports Cardiology UK and one of the first consultant cardiologists in the UK to complete a master's degree in sports cardiology. He provides expert cardiac assessment, screening, and exercise advice to individuals across all levels of sports, from recreational athletes to professionals, and works with a number of sports teams. Nationally, he is one of only a small number of cardiologists on the Football Association Advisory Panel and has extensive experience supporting athletes with both normal physiology and underlying cardiac conditions. Professor Augustine, thank you for joining us today. I will hand over to you.
Thanks very much, Janelle. Can you see my slides? I'm not sure if I've done this correctly. Are my slides coming out? You can? Okay, perfect. Yeah. Okay. So thanks for the invite. I'm Dan Augustine. I'm a cardiologist. I'm based in the southwest in Bath, and I work at the One Heart Clinic in Bristol. From a sports cardiology perspective, I work with a number of different associations and in the southwest, different sporting teams. What I hope that we'll achieve today is to give you an understanding of what factors can affect structural and cardiac adaptation in athletes. We'll talk about some red flag symptoms. We'll focus quite a bit, if it's okay, on ECG interpretation, what I think is important in terms of primary care, and then talk about risk assessment in master athletes. Master's defined as anyone doing a fair amount of aerobic exercise over the years, and then they get to over the age of 35, 40. So cardiac adaptation to exercise varies with a number of things, sporting discipline, age, and gender, as well as ethnicity. And all of the adaptations that we can see is termed athlete's heart. So you can get electrical changes such as bradycardia, T-wave inversion, increased voltages. You can get structural changes such as enlargement of the cavities. And both these electrical and structural changes lead to functional adaptation, so increased stroke volume, as well as improved diastolic function, all to aid the athlete to be as fit as they can. But these changes that we see can cause certain conundrums that we see in terms of sports cardiology. So you can have athletes that have an enlarged right ventricle and T-wave inversion, and is that due to athlete's heart or is it due to arrhythmogenic right ventricular cardiomyopathy? You can have athletes where there's a dilated left ventricle and the ejection fraction is low normal or mildly reduced. Is that due to athlete's heart or dilated cardiomyopathy? And another common conundrum is you can have athletes with athlete's heart and the left ventricular wall thickness is slightly thicker than it should be. Is that due to sports or is it due to hypertrophic cardiomyopathy? And we'll talk about ways to differentiate between the two, physiology versus pathological process. In terms of ECGs, I'd like to talk about T-wave inversion. So the first thing to say is that most athletes will have normal ECGs, but in a minority of athletes, you will get T-wave inversion. This is a nice study looking at black and white male and female athletes. And what they saw was that black athletes had more T-wave inversion than white athletes, and black male athletes had more T-wave inversion, deep T-wave inversion, than black female athletes compared to white athletes, irrespective of gender. And when we see this deep T-wave inversion in black male athletes, it's usually confined to leads V1 all the way up to V4. And when we see that T-wave inversion, it's preceded by convex ST elevation. And I'll show you an ECG shortly. So one of the takeaway messages is that you can have black male athletes with quite profound deep T-wave inversion in leads V1. It can spread to V4 with some preceding ST elevation. Another important takeaway message is that ST depression should be felt to be always abnormal until proven otherwise. It's really rare to have an ECG that's due to physiological change showing ST depression. So we talked about black athletes. What about the white population? So this is nice work looking at a youngish, 16 to 35 years of age, white population having ECGs. So the takeaway messages here is that as opposed to the black cohort that we saw where males had more T-wave inversion than females. In the white population, the female athletes had more T-wave inversion than the male athletes. And when we see T-wave inversion in white athletes, it's usually confined to V1 and V2. So that's acceptable and thought to be normal. If it extends more than V2, then we start to think about other processes going on. This is work that we published a couple of years ago where we looked at the adolescent athlete's heart. So we had about 1,000 adolescent footballers and different. And the good thing about this cohort is that it was different ethnic groups. So the black bars are black athletes, the white bars are white athletes, and the grey bars are mixed black-white. One of the things I want to highlight here to take away is that left ventricular voltage criteria for left ventricular hypertrophy is really common in athletes, and unless you've got symptoms or a family history of something that concerns you or a high blood pressure, I wouldn't investigate isolated left ventricular hypertrophy further on an ECG in an athlete. The other thing to point out from this graph is the last two columns, where we can see T-wave inversion inferiorly and laterally is uncommon. And so if we have an athlete who has inferior and lateral T-wave inversion, then we need to think about a pathological process. These are my takeaway messages for T-wave inversion. So the first thing to say is that in all athletes, black or white, usually the ECG is normal in terms of T-waves. In black athletes, in men, it can be normal up to V4. It's associated with some preceding ST elevation. In white athletes, the T-wave inversion is more common in females than males, usually isolated in V1 and V2. Red flags, ST depression or inferior or lateral T-wave inversion. If you're seeing younger athletes under 16, then you can have a juvenile pattern ECG. Their hearts are growing and changing. And so you can get T-wave inversion in V1 to V4 up until the age of 14, which usually regresses by the age of 16. The reference to this paper is at the bottom. It's a really nice summary of athletic changes in ECG and what's thought to be normal, what's thought to be borderline, and what's thought to be abnormal. So for this talk, I just want to concentrate on the normal findings. So if you have an athlete with voltage criteria for hypertrophy, so that's left ventricular hypertrophy or right ventricular hypertrophy, then that's normal. Partial right bundle branch block is normal. You can often see athletes with J-point ST elevation, so it's a concave ST elevation, and it's usually globally 1 or 2 millimeters, and that's normal. And we've talked about the black male athletes who can have T-wave inversion to V4. If you have T-wave inversion and you're under 16, you can have a juvenile pattern V1 to V3, which is acceptable. Sinus bradycardia, what would I say in terms of generally acceptable? Certainly anything over 40, and it really depends on how athletic the individual. Those who have heart rates in the 30s are really highly aerobically trained. So think about the sports they're doing. So if you've got a weightlifter who's doing more resistance stuff, for instance, and they have a bradycardia, then I'll be thinking actually this potentially isn't due to physiological change. Towards the bottom there, you can see ectopic atrial or junctional rhythm. So a junctional rhythm originates in the AV node, so you don't have a P wave, but it's a regular rhythm. And an ectopic atrial rhythm is where you have inferior P wave inversion. So an inferior leads to P wave inverted, which highlights that the P wave, the sinus beat, is not originating from the sinus node, but it's lower down in the right atrium. And both of those are normal, and these aren't these aren't seen infrequently in particularly highly trained younger athletes. And when we have them on the couch, it's nice to get them to exercise, to do some gentle leg raises. And what you'll see is that this ectopic atrial rhythm or the junctional rhythm just reverts to a normal sinus rhythm at slightly higher heart rates. First degree AV block, in terms of physiological adaptation, is normal, and this is usually our aerobically trained athletes, certainly acceptable up to 300 milliseconds. And then we see a lot of Mobitz secondary heart block type 1, so that's Wenckebach. So that's when you have a progressively prolonging PR interval and then a dropped ventricular beat. And that's just a sign of high vagal tone and athletic adaptation. And that's usually seen overnight. And in an asymptomatic individual, doesn't merit any further follow-up. There are some borderline findings, which I'm not going to go into any detail, and some abnormal findings. So I think if we concentrate into the primary care, what are the normal findings? And anything that falls out of there certainly would merit discussion, onward discussion. If there are normal findings in an asymptomatic individual, then we wouldn't do anything else. If there are borderline findings in isolation, we wouldn't do anything else. 2 or more borderline findings or abnormal ECG findings, then it will be reasonable to refer for further evaluation. This is an ECG. This is an ECG of an athletic individual. We can see there's a sinus bradycardia. There's partial right bundle branch block morphology in lead V1, and we can see that there's voltage criteria for left ventricular hypertrophy, all in keeping with athletic adaptations. So it doesn't require any further follow-up. This is an ECG of a black athlete without any pathology going on. It's a black male athlete. We can see that quite deep T-wave inversion that I was talking about to V4, and preceding that there is convex ST elevation. So this is all physiological change in a black, highly trained endurance athlete. Some abnormal ECGs I'll go through. So this is a 21-year-old female Caucasian triathlete, and you can see we talked about Caucasian female ECGs and that T-wave inversion being acceptable in V1 and V2. We can see here it extends down to V3. It's a 19-year-old female endurance athlete, no relevant symptoms. And what we can see here is that this is ECG 1 of 2. If you look at the rhythm strip at the bottom, you can see that you can sometimes see a P wave, but sometimes you can't see a clear P wave, and there's a sinus bradycardia. So this is sort of like an intermittent junctional rhythm. And so what we would do what we did with this athlete is just to get her to do some straight leg raises to get the heart rate up. And we can see that at higher heart rates, her sinus rhythm kicks back in. And so we know that this is physiological adaptation, and we don't need to worry about any abnormal electrophysiological mechanism causing her intermittent junctional rhythm. I'll move on to red flag symptoms. So chest pain, I would differentiate this by age group. Those under 35 versus those over 35, or certainly over 40. If you're over 40, we're thinking about coronary disease as the biggest cause of mortality in athletes over 40. If you're under 35 and you have chest pain, then we're not thinking about coronary disease. We're thinking about rarer conditions like anomalous coronary arteries, where a coronary artery will originate in a different sinus and travel between the aorta and the pulmonary artery. And as you're exercising, they expand and squash the artery. That can lead to arrhythmia. We're thinking about post-viral symptoms. Have they had a myocarditis or a pericarditis? The other thing is that it might not be cardiac. I only got the back end of the last lecture, but chest tightness can often be due to a respiratory cause, and sometimes asthma or exercise-induced laryngeal obstruction. Palpitations, the important thing for me is whether they're associated with pre-syncope or syncope on exertion. That's a red flag. It's important to get a clear history of the palpitations. It means different things to different people. Often they sound clearly quite benign, ectopics. Is there altered consciousness with palpitations? And in terms of altered consciousness, that's not an uncommon symptom that athletes will report, particularly after putting a big shift in. So after high intensity bout of exercise and they stop quite suddenly, blood pressure changes, and they'll have altered consciousness, and that's fine. We also hear it a lot in resistance training athletes as they're valsalvering, and they'll have altered consciousness, which is fine. What's the red flag for me is, are they having altered consciousness predictably as they're increasing the intensity of their exercise? Moving on to trying to differentiate physiological change from hypertrophic cardiomyopathy, the take-home messages here are that most athletes, black or white, will have normal wall thickness. The diagnosis of hypertrophic cardiomyopathy is when there's a wall thickness of greater than 15 millimeters. So it's definitely a red flag if you're seeing an echo report of greater than 15 millimeters. In black, particularly black male athletes, you can have increased wall thickness in a minority. 10 to 12% can have a wall thickness of between 12, 13, 14 millimeters. In black female athletes, we don't see it that thick. We see a minority up to about 13 millimeters. In white male athletes, a minority exceed normal wall thickness. So it's unusual in white athletes to have physiological change causing hypertrophy. And it's hardly heard of at all in white female athletes. Moving on to dilated cardiomyopathy and athlete's heart. So you can have a proportion of athletes where the top graph, this is Olympic Italian athletes, 14% of them had a dilated cavity. And in the bottom graph, this is Tour de France cyclists. A proportion of them had a dilated cavity and an ejection fraction that was low normal or mildly reduced. So you can have this conundrum where you have a dilated left ventricle, slightly low normal ejection fraction or slightly reduced. How do you differentiate that from athlete's heart and a mild form of cardiomyopathy? Take-home messages in terms of athlete's heart versus dilated cardiomyopathy for primary care really are in the highlighted bits here. So usually things are normal. If you see an echo report that says there's an enlarged left ventricle, it's usually going to be your highly trained aerobic athletes, and usually you'll have balanced chamber dilatation. So it won't just be the left ventricle that's dilated, the atria and the right ventricle will also be dilated. If you have that dilatation and a mildly reduced ejection fraction, think about what sports they're doing. These are going to be really highly trained endurance athletes. It won't be your resistance weightlifter. Another important thing on echo reports, diastolic function in athletes is always normal. In fact, in endurance sports, it's supranormal, which helps them to augment their venous return, to augment their stroke volume. And so if you have any echo report that says, impaired relaxation or diastolic function, and start to think about that might be a pathological process. I'm going to skip through some of these slides just because of time restraints. In terms of risk assessment, in those over 40, it's just the standard cardiovascular risk assessments that we'll be doing, that you do in primary care every day. I do find risk scores useful in those without known cardiovascular disease who are asymptomatic and plan to do high intensity competitive endurance sports. In Europe, they use this score, which is different to the Q risk in that it's a risk score for a fatal cardiac event over 10 years. And those felt to be 5% or higher. I think it's very reasonable to offer them a treadmill test or some form of exercise assessment. What about after myocardial infarction? It's important that we look at their risk factors closely and control them as well as we can, as we would with any patient. Those undertaking sports, who's at higher risk? Well, it's those who have bystander disease that's still significant, those with a reduced ejection fraction, those with arrhythmias, ischemia. So the recommendation in these athletes, recreational athletes, will be to stick to mild to moderate intensity. If they want to push themselves harder, then that needs more thought and an exercise assessment and an individualized approach. In those who have had stents and are at low risk, then I would leave it at least 3 months before undertaking competitive or high intensity sports. In terms of heart failure, again, optimization is important, risk factor control and optimal therapy. It's important to have a good discussion with the patient that they're realistic in terms of their functional capacity now if this is a new diagnosis of heart failure. Those with heart failure who are at higher risk are those who have poor functional status, reduced ejection fraction, myocardial scar or arrhythmia. Initial thoughts in terms of exercise prescription in those with heart failure who want to undertake low to moderate intensity. Really important they're asymptomatic and their medication is well controlled optimally. If they want to undertake high intensity competitive sports, then they need to be asymptomatic and stable. It needs to be an individualized approach to this, and certainly ejection fraction needs to be sort of in the mid-range reduced ejection fraction, so nothing that's significantly reduced. They're the learning objectives that we've covered, and I'll be happy to answer any questions if there is time.
Yeah, thank you very much, Professor Augustine. And I believe Dr. Haji just replied the questions in the Q&A box. And if you have any other questions, just feel free to use the time now to drop it in the Q&A box. And then, also, you know where to find us. So just feel free to send us emails about questions you have. And thank you again, Professor Augustine and Dr. Haji, for sharing your expertise and practical guidance. And thank you to all of you for joining us today. A follow-up email will be sent shortly. And if you have any further questions, just like I just mentioned, please don't hesitate to get in touch. And we hope you found the section useful and relevant to your clinical practice. And we look forward to welcoming you to our future webinars. Thank you, guys, and hope you enjoy the rest of your day. Bye.